Hey everybody. To go along with that video we just sent out reminding us all how to use ramp triage in an MCI event, this lecture will go along with it, and this is on the medical management of MCI patients and how that differs from our normal day-to-day operations when we encounter single victims, and how those algorithms might change when approaching a large-scale event. So, overall, how does that care differ on an MCI scene versus a regular individual patient? Painting with broad strokes, we're going to be less focused on specific protocols and care and more overarching and providing the most amount of care we can for the most amount of victims. And really how we do this is by performing life-saving interventions only on these scenes, not hanging around and doing things like IVs or 12 leads or getting blood sugars. Really focusing on what we can do to save a life in that moment and how to get them to the hospital the fastest. And really our focus is on rapid transport. How quickly can I get them from point A at the wounding scene to point B, being the ER? And that's how we're going to have the greatest impact and save the most amount of lives on these scenes. And while we're on the subject of overarching themes we're looking for here, one of them is the 20-60-90 goal. Quite simply what this is within 20 minutes we want point of wounding care. So from the time this event occurred, whatever it may be, within 20 minutes we want to provide point of wounding care. Within 60 minutes we want to get all critical patients transported off the scene so that within 90 minutes all critical patients are in surgery. And that's how we have the greatest survivability of these incidents. Now, when it comes to the 90 minutes patient being in surgery, there's not a lot we can do there to make them get into the ER faster, the OR faster, other than recognizing them on scene and getting them off scene quicker. So by being faster with the 20 and the 60 minutes, we provide them more of a buffer to get within that 90-minute goal in the surgical suite. Let's take a look here at the last 50 years of terrorism-related data when it comes to fatalities and injured victims. And if you look, the vast majority have no victims that are fatal or non-fatal. And the next most common after that would be 1 to 10 injuries, and then 11 to 50. So that makes up the majority of terrorism-related events. I believe we could handle that as an agency today. We would have to adjust some things, and our medical management would be a little bit different. But realistically, we should be preparing for a 50 or less event. And if you really see the outliers here in the data fields are the 51 to 100 injured or fatality, or greater than 100 injuries or fatalities. Those are really, really rare when you're looking at the data set of 168,000 incidents. Now, for the next several slides, we're going to be covering the individual types of MCI events that we could encounter and some of their injury patterns. When specifically looking at a terror attack, the most common method used for these was explosions and armed assaults, which were about 59% of all the incidents out of that 168,000 incident data set. The common wounding patterns in these we can expect to find, multi-system injuries from explosives. And if you look there to the right, that's indicative of, that primary, secondary, tertiary effects of an explosion. Primary being the explosion, secondary is what it's thrown at you, tertiary, what you hit when you land. We're also going to encounter penetrations to the chest and abdomen, both from explosions as well as from armed assaults. Orthopedic trauma shouldn't be overlooked. This can occur due to explosions, vehicle-borne issues, or even gunshot trauma to the leg can affect your femur and shatter it. Lacerations, and specifically when it comes to the explosives, barotrauma from the blast waves. And these affect our hollow organs like our lungs and our stomach, as well as our ears from the rapid shift in barometric pressure. And not to be overlooked, which often is though, is the psychiatric side of these events. It is not uncommon on a MCI terror attack to encounter victims who have no physical injury, but are psychologically injured and may not be able to assist you in rendering aid to themselves or in identifying if they're actually wounded or not. So we need to take this approach when we come up to these patients that there may be some psychological trauma that we're not able to address right away. Another potential provider of mass casualty events are natural disasters. Things like tornadoes, floods, wildfires, earthquakes. And aside from the earthquake, we've had those other three events happen locally within our fire district numerous times within the last decade, between tornadoes, the Boulder floods, the Marshall fire. Typical wounding patterns we're going to see with this are orthopedic in nature, fractured limbs, busted ribs, sprained ankles, things like that, nothing life-threatening. Additionally, we'll come across lots of lacerations and abrasions. The concern there is the secondary infection. As you can imagine, getting an open wound into the Boulder flood waters probably is not going to turn out too well. And one that has a high incidence rate but isn't really spoken about much is respiratory problems. So with the Marshall fire, obviously, but other events that kick up large amount of airborne particulates can put those with a predisposition for respiratory problems, such as small children, elderly adults, those with COPD or asthma or reactive airway diseases. And it can really increase the amount of hospitalizations due to respiratory compromise from these people. So it's something to keep an eye on as events progress over time. Perhaps the scariest of the MCI events we could encounter is luckily the rarest, which would be a CBRN event. These are very rare. Less than 0.1% of all mass casualty events involve CBRN. And even of those, most of the time the injuries are from an explosion, not the actual CBRN itself. Injury patterns on these are going to vary wildly depending on what it is. They can include coughing if it's an airborne irritant into the lungs, vomiting if it is a radiation-related event and you've had a large dose. It can include burning sensation if you've gotten something on your skin, as well as chemical burns. The big one that we could possibly see would be the nerve agent-related events, which are the dumbbells. And it used to be sludge. Now it's diarrhea, urination, meiosis, bronchoria, bradypnea, bradycardia, emesis, lacrimation, and salivation. And of those, we say that the three Bs are the fatal ones: the bronchoria, bradypnea, bradycardia. So the slow heart rate, the slower respiratory rate, and the overwhelming amount of secretions within the lung cavities themselves. And we'll discuss treatment for these further on along in this lecture. Let's look at crowd events now. And these can be primary or secondary. So like a secondary would be a concert event or a sporting event, and there's a shooting or explosion or any sort of chaos and people rush to an exit. It only takes 3 deep worth of people pushing against you to make it so that you can't suffocate and you can't breathe when you're pushed against an object. And an interesting thing here is, how do we anticipate crowd movement? Well, large human crowds exhibit a fluid-like collective behavior that can be predicted solely on hydrodynamic theory. And what that means is a crowd moves as a collective, not as a sum of individuals. It moves as a body as a whole. It moves like water flowing around objects. And quite a bit of what we know about crowd events was actually studied at what you see a picture of here, which is in Mecca. And they discovered that that 3 deep can cause suffocation and how crowds move and things like that. Wounding patterns we're going to see here, once again, orthopedic in nature. We're going to have a lot of crushing injuries. The fatal are often due to trampling or compression due to reduced ability to breathe. So if we go to a crowd event, especially if it's still happening and there's still an evacuation in process, recognize that, like water, crowds are going to flow to the area of least resistance and move as a whole. So we've talked about a few different ways MCIs can occur and some of the wounding patterns we'll see. Now let's get into the treatment, which is what this whole lecture is actually about. What's the medical management here? When it comes to an MCI, let's talk first and foremost ALS versus BLS. And this is where I talk about how us medics kill a lot of people. It's no secret that trauma systems around the country that have BLS responders versus ALS responders have higher survival rates. And that's because we as medics like to play around and do a bunch of things. We remove the emphasis from rapid transport. Looking at this, a 2013 study found no increase in survival for patients who receive pre-hospital IV fluids or needle decompressions. And in fact, as medics, the prevalence of pre-hospital tension pneumo is grossly overstated and is actually only occurring in about 0.3% of penetrating chest trauma. So that's incredibly rare. Odds ratio for death versus ALS versus BLS care. So if a medic provides you care versus an EMT, you have a 2.5 times greater chance of dying. And this study took into account the severity of injuries on these patients. So it strictly came down to starting ALS care versus BLS care, 2.5 times greater chance of dying. And then when they looked at 165,000 trauma patients, they found that EMS scene time directly correlates to increased mortality, which makes sense when you think about how people can bleed to death and all these contributing factors to mortality and trauma, and how very few of them we can actually save. How we save people is by getting them to hospitals, getting them to ORs and ERs and advanced levels of care, and medics tend to stay around on scene too much. So really from this slide, take away BLS is best and rapid transport is key. So let's get into some specific medical management of MCI patients now. Now these you're going to see coming up on these slides are for MCIs. These aren't for if you have just a single patient, treat them per the protocol. But on a broader scale, we need to talk about how we're going to medically manage things. So let's start with extremity hemorrhage. And we're not just talking about arterial bleeding. We're talking about significant venous bleeding or truly any moderate extremity hemorrhage that can't be immediately controlled with direct pressure. Just go to a tourniquet in an MCI scenario. Just cut that bleeding off when you can. Initially, we're going to place it high and tight, as high up on that groin or in that armpit as you can get it. We'll worry about adjusting them possibly later. And another thing that's not really taught is for femoral artery occlusion, it can usually take about 4 inches of compression. And how big are our current tourniquets, both the SAM or the Cat9 tourniquets? They're 2 inches. So in reality, you probably need to double those up on the femoral artery. Moving from extremity hemorrhage to junctional hemorrhage. So when I say junctional, I'm talking about the crease of the neck, the armpit, the groin, areas where you can't get a tourniquet, yet there is still excessive hemorrhage that you can apply direct pressure to. We're not going to cover in this lecture how to wound pack. We'll cover that in a hands-on station. But the gist of it is you need to pack deep and pack hard into there. And remember, when trying to control hemorrhage with this, it's about pressure, not absorption. So it's not about just piling lots and lots of gauze or combat gauze into the wound. It's about applying direct pressure into that bleeding vessel. Once you've gotten as much gauze as you can get into it, you need to put a lot of weight into it. So basically your whole body weight's worth of pressure onto it. For how long, you may ask? Well, in a non-clotting additive such as like a Curlex, you're looking at 10 minutes of pressure. If you have a combat gauze, you're looking at 5 minutes. Now in an MCI scene, do we have the resources to really do that? And the answer is most likely not. However, what we can do is we can wound pack that and then use bystanders and tell them, hey, give me your hand, put as much pressure as you can on this wound and push down on it. Or we can use adjuncts such as an Israeli bandage or an ACE wrap to really crank down on that to give that patient the best possible chance of stopping that hemorrhage. When it comes to external hemorrhage in general, remember your time frames in some of these. And if you have a full femoral rupture, you've got 3 to 5 minutes before it's fatal. A brachial artery, you've got 6 to 8. So if they're true arterial ruptures, we might not be able to get there in time. However, if they're just partial or significant venous bleeding, or even just excessive capillary bleeding from multiple soft tissue injuries, we can get there in time. Now, if this scene is large, imagine a Las Vegas size shooting, covering multiple blocks. How do we get to all these patients in a timely manner while we're still trying to do things like triage and assess the scene? Well, the answer for that is going to be a hemorrhage runner. And what a hemorrhage runner is that first unit that pulls on scene as that officer gets out and does their size up and tries to determine what resources they need. The person that's riding in the back seat or the EMT or the medic that's sitting back there takes the hemorrhage control kit, which is your basically your RTF bag with all your gauze, all your tourniquets, all your hemorrhage control devices, and they just run. And their whole job is to run that scene and just start applying hemorrhage control devices, not stopping to do triage, not stopping to do other things, literally just running along and making sure everybody who needs a tourniquet has one, everybody who needs a wound packed is getting a wound packed, anybody who needs pressure applied is getting pressure applied. And that's the sole job of a hemorrhage runner. Moving on from how we would address massive external hemorrhage, we'll move into airway. So once again, we fall back to the basics. The first being a jaw thrust, open up somebody's airway if they need it opened up. If they can take one, apply an OPA. However, recognize that loss of a gag reflex is associated with a significant increase in mortality and trauma. So if that patient handles an OPA, they're most likely not going to survive this event because it is an MCI, remember? So we can't apply a ton of care to this individual person if we have dozens of victims. An MPA can also be used. A 26 French is the most common that can be used for adults. So if you're stacked and carrying a bunch of NPAs rather than trying to size them each time, 26 Frenches is usually the way to go. And then these patients that might not be completely coherent, we can't just leave them on their back, and then they could potentially asphyxiate on secretions. So once you've placed an NPA or an OPA, or you've opened that jaw thrust and they're not deceased, depending on how you've triaged them, put them in the recovery position. So there's a photo of that to the right, how you would lay them on their side, position their arms, and roll them so that they're kind of on their side with their mouth down so they can drain any secretions. And we will practice this as well during some hands-on scenarios. After airway, it only makes sense to cover respiratory. So how are we going to do treatments for this? Well, for a probable tension pneumothorax, which for us in an MCI scenario would be significant penetrating chest trauma or blunt trauma to the thorax combined with difficulty breathing, would be indicative on an MCI of potential tension pneumothorax we need to address. However, if you remember that slide earlier, they're not as common as we expect. So don't go all out on these and start decompressing everybody. For chest decompression, use our 10 gauge, 3.5 inch needles. And if you're picking a spot, the lateral location has a far higher success rate than the anterior location on the chest. And then hopefully in the future, we move towards a finger thoracostomy, which is the way EMS in general across the country is heading and has a obviously far higher success rate than a chest decompression. For a flail segment, if you can encounter those on a scene, especially in an MCI, there is no treatment for that. We no longer wrap with the bulky dressing or the saline bag or even the sandbag if you've been around long enough to remember those. Just support ventilation and oxygenation for that patient. And it should be noted that vent-associated tension pneumothoraxes can occur within 2 minutes of mechanical ventilation, so be careful if you decide to bag somebody. However, once again, this is a medical management of MCI patients. We really shouldn't be bagging MCI patients because if I'm bagging this patient, I can probably be utilizing my resources elsewhere to save more people. And for those who paid close attention when I was talking about wounding patterns of various types of MCI events, you would have noticed that the most common one we find is orthopedic in nature. So it only serves that I discuss how we would treat orthopedic injuries on an MCI. First and foremost is don't waste time on splints initially. If I've got dozens of victims, I don't need to splint that fractured wrist, or I don't need to splint that sprained ankle. We really shouldn't be wasting time with splinting at all initially on an MCI event. Now, if you've got them back to the casualty collection point and you have poor CMS to a distal limb, you can make a single attempt to realign it. However, once again, with all things we talk about, don't delay transport on any of these victims. Get them in the ambulance, get them moving. One piece of equipment that shouldn't be overlooked that could be potentially life-saving is a pelvic binder. So apply the pelvic binder, and anybody you suspect has an open book fracture. If you look to that picture to the right, before and after application of a T-pod, which is just one of the versions of the pelvic binder that's out there, it can really slow hemorrhage and help control internal bleeding and maybe buy those patients some time to get to an OR. All right, thermal burn treatment in regards to a large event doesn't change too much from how we would treat a single burn patient. First, stop the burning. This is key. You may need to use water for this. Remove their burned clothes. Cut them off, remove that burned article of clothing from them, and prevent hypothermia. Do this with our space blankets. And really, we used to really be concerned about, is it a sterile burn sheet versus a non-sterile burn sheet? That's not of concern. We're in a mass casualty event here. Use a regular sheet, use a space blanket. They're going to be debrided and given antibiotics anyways, and they're already at high risk for secondary infection. Us using a sheet off the pram is not going to make it any worse. The difference would be for the MCI version of thermal burns is we don't worry about IV fluids at all. We don't use the Parkland formula anymore anyways. Now we use the burn associations, 500, 250, 125, depending on age, fluid resuscitation doses. On an MCI, we're not going to do that. We're just going to stop the burning, get the burn clothes off, prevent hypothermia, and then address any airway concerns that there may be associated with this. Patients suffering from a traumatic brain injury in a MCI style event traditionally don't have great outcomes because we're not able to render the care they need. What we can do on these large scale events is elevate their head, which is no different than how we would treat them now. Try to put them at about a 30-degree angle if possible. Also, oxygen is utterly important. A single hypoxic event increases mortality rates significantly on a traumatic brain injury patient. And this can be difficult because those initial arriving units, as they're out into the field providing care, probably won't be carrying an oxygen cylinder with them. So that treatment would be delayed at best if they even got it. And a lot of our previous pre-hospital treatments are mostly outdated. Turns out that hyperventilation from us is not super effective or warranted anymore. And things like Lasix or other diuretics like mannitol aren't really given pre-hospital anymore. So the most we can do for these people is elevate that head, assist the airway if you can. But once again, think MCI. You're not going to have the ability to waste time doing that. And provide oxygen at the soonest possible moment. Earlier on, we discussed MCIs and how rare they are with CBRN events. And I mentioned that we would discuss treatment modalities for them later. And we'll cover that now. The first one being nerve agents, and these can cause MCIs. The biggest one that comes to mind is the Shinrikyo Tokyo subway attacks, where you had hundreds of people exposed to a nerve agent. And the treatment for that is large amounts of atropine along with Tupam. These are drugs that are now carried in various units around Boulder County, thanks to the ToxMedic program that's been implemented, which are also protocols that have been accepted by the protocol committee. Large-scale cyanogen events, you'd have cyano kits. However, MCI, we're not going to have that many of them available. Hydrofluoric acid could occur. We have that stored in numerous places in our district. And the important thing there is it's a calcium leaching chemical. And the treatment is calcium gluconate applied directly to where it's burning. And radiological, good news, bad news situation there is for us, there's no pre-hospital treatment. However, if there is a radiological event, which could occur on I-25, there's large amounts of nuclear material moving up and down I-25 every day. If you're exposed to a large radiation dose and you have vomiting within 30 minutes, that's a 100% fatality rate. And that's really the only triage algorithm there is for a radiological event is vomit within 30 minutes, 100% fatality rate. With all victims of trauma, MCI or not, but specifically with MCIs too, we really need to be worried about hypothermia management. For every 1 degree Celsius the body temperature drops in a trauma patient, there's a 10% increase in mortality rates. So you can imagine on a cold day or even overnight sometimes during the summer, how you could drop a degree of Celsius body temp very quickly. We can reduce this by things like a space blanket, setting them on top of blankets. The biggest thing is get them off the ground, because that ground will just suck the radiant heat from a person or a casualty. So as soon as possible, get these patients off the ground, put a barrier between them, wrap them in a space blanket, ensure warming methods, because we want to give them every opportunity to survive this mass casualty event, and keeping them from getting cold is going to be a great way to do that. I touched on it briefly earlier, but now we're going to cover it in more depth, which would be IVs and fluids in an MCI event. And this also kind of applies to how we treat our normal patients. Average time for an IV is 8 to 12 minutes, and this increases your scene time on average about 5 minutes per patient, which those numbers sounded high until you start actually timing these scenes, and it does take about that long to get patients moving when you say, like, oh, I'm just going to get a quick IV. Additionally, a retrospective study found zero benefit to pre-hospital administration of fluids in patient survivability from trauma, and it increases all 3 items of the diamond of death, which is now 4 items. Additionally, every ALS pre-hospital procedure performed was found individually to be predictor of increased mortality. So things like IVs and fluids was found to increase mortality rates from trauma. However, there may be some room for TXA and calcium within trauma patients in the future, however, not really on an MCI scale. I mentioned the trauma diamond of death. You may have known it as the trauma triad, but it's now expanded to be the diamond. And these are the four things that kill trauma patients outside of the actual trauma themselves. And as you can see, we're probably directly responsible for a lot of these. So there's acidosis, coagulopathy, hypothermia, and hypocalcemia. And if you relate it to the previous slide, the one thing we normally do for a lot of our trauma patients is IV fluids. And by doing that, we're increasing all four of these. So acidosis, the human body's pH is 7.35 about. pH of saline is 5.5. So we're giving them this acidotic fluid that on a normal patient, they could easily adjust their pH balance to accept that. However, on a patient who's dying from a hemorrhage, they're not really going to be able to have the systems in place to put that buffer in. Coagulopathy, our saline contains no clotting factors. Hypocalcemia, saline has no calcium in it. And hypothermia, none of the saline we're giving is 98 degrees warm. So really this is a good piggyback on the previous slide with MCIs and also trauma in general. Maybe hold off on those fluids. Like I said, the new one in there makes it the diamond is hypocalcemia. And the next slide, we're going to show the new research of why that plays a factor in increased mortality rate. This is the body of research that's kind of cutting edge within the last couple of years on the role of calcium in trauma mortality. And it really plays a factor in everything that's associated with increased mortality rates. So hypothermia causes a decrease in liver metabolism of citrate, which then the liver binds with calcium, leading to less available within the blood. Low calcium rates in the plasma are necessary for factor for clotting. Hypocalcemia drops due to blood loss in general, and then transfusions further exacerbate this. So if we ever move to a blood product program where we're pushing blood pre-hospital, you'd also be giving multiple grams of calcium. And lower calcium levels also lower pH, which prolongs clot formation and makes you more acidotic. So as you can see here, we're not there yet, especially with MCIs, where trauma patients receive calcium, but we may be there very soon. All right, so you've triaged all your patients, you've brought them all back to a casualty collection point. Now what? So let's talk casualty collection point versus ambulance extraction point. Are they different? Are they the same? Can they be the same? I would say yes. So casualty collection point is just an overarching term for where we would bring all the casualties to provide further medical care before they're transported. An ambulance extraction point is the point where I physically am loading them on ambulances to leave my scene. If possible, make these one and the same so that you're dragging the patients to where they're going to be moved immediately onto ambulances. Because for every CCP that's used, evac time is increased by approximately 5 to 20 minutes per patient, which can have devastating effects on mortality rates. Patient care should center solely on external hemorrhage control and rapid transport, so we're not messing around with a lot of things. And in fact, the efficacy of any additional treatments is minimal, if not detrimental. So if it's not life-saving, we really shouldn't be doing it. And lastly, who staffs this? Who do you put there? Do you put your brand new medic there, or do you put your seasoned medic there? I would say if you have the choice between the two, put your seasoned medic here, because you can assign your brand new medic to go do triage, because especially using ramp triage, it's so easy. Send anybody to go do that. This is where you want your really seasoned medic who has the ability to determine, now that they've been brought 40 red patients, who's the reddest of the red. I need them to have that clinical Rolodex in their head of who gets assigned here, knows who's the sickest, who has the greatest chance of survival, and then also who's most likely not going to survive so they can write them off. This is an incredibly difficult position and probably the hardest one on that MCI scene. However, it is also probably the most important. So let's say you got assigned to run that CCP and you might not be that senior clinical person, and you're looking for a tool to assist you, and who's the sickest of the sick? Well, the good news is with simply a BP cuff and the ability to palp a pulse, you can determine that. And that's what's called the shock index. So what is it? Well, it indicates the level of occult shock specifically from acute hemorrhage, which is incredibly important on a lot of these MCI scenes. The formula for it, you take the heart rate, you divide it by the systolic blood pressure, and if that number comes out to greater than 0.9, you have an increased mortality rate, which, are we really going to be doing math on scene? Probably not. The down and dirty of it, if your heart rate is greater than your systolic, so if you're palping a blood pressure, if your heart rate's 130 and you have an 80 palp pressure, that's bad. The wider that gap, the higher the shock index, the higher the mortality rate. So that is a simple tool you can utilize in a CCP to determine who's your sickest of the sick or who might be too far gone to save. So we've covered hands-on care that should be provided. We've talked about the CCP. We've talked about the shock index. Really what's left to talk about is transport is truly the priority now. After that initial medical care is provided, rapid transport. And how are we going to accomplish this? Well, I advocate remove the stretchers from the ambulance when it pulls on scene, because if an ambulance pulls up, I can only put one critical in the back of that ambulance on that stretcher. In reality, these stretchers are just taking up space. So pull that stretcher out, put it to the side, and I would put 4 or 5 victims on the floor of that ambulance. Because once again, care is not going to be really rendered in the back. It's just going to be hemorrhage control, and that ambulance is going to be a meat wagon, a clown car. How many can I fit into it to get into the hospital? So medics need to recognize, gone are the days on a major MCI of saying, oh, I can take 1 red and 2 greens. No. We're transporting all the reds off scene before I start putting greens in ambulances. And I do that by packing that ambulance with as many as I can put in there. PD transport, like in Aurora, this happened a lot. If there's PD officers on scene willing to take patients to hospitals, let them go. If you can spare somebody in the back of the cop car to help assist with care, great. If not, that's 1 more patient off your scene into a hospital. And ultimately, too, don't forget about your air resources. There are numerous air resources within Colorado that if we call for, we could get a significant amount of them on scene rather quickly. If we utilize air, I would suggest using those for our unique patients like pediatrics or burns, or and then when you get that patient in that helicopter, fly them far away. Don't fly them to the local hospital. It's most likely going to be overwhelmed anyways. And recognize that that air resource you just utilized is probably gone to you now. Once it's flown your patient to that ER far away, they're probably going to be tied up, decompressing local facilities and taking patients and transferring them. So you probably only get 1 shot with each helicopter, so make it count. And really, why that emphasis on rapid transport? Well, from what we learned at Fort Hood, Boston, and San Bernardino is, if they arrived alive at the hospital, they lived. Every patient who arrived at the ED alive from those events survived them. So it really hits home that rapid identification of the most critical through triage, rapid application of life-saving interventions for the or for the traumatically injured, and then rapid transport is how we save lives. Less is more, speed is key, and we can have direct impacts on survival rates if we're just faster. So in conclusion, we should focus on life-saving interventions, rapid transport, and with a scene management emphasis on removing bottlenecks where possible. That becomes part of a larger discussion. Where we remove bottlenecks for the medical management is none of those ALS skills. Truly just focus on what's the best for the patient at that moment to get them to the hospital alive. I thank you for listening to me for the last 35 minutes. And if you have any questions, feel free to follow up with me by email, and I'm happy to answer them for you. Thanks.